This week on the BackTable podcast.
The challenge that I face, I'll tell you, is that with the way medicine in the United States is, right? Like I can't just say, okay, I'm going to take all of my stone patients and send them to this person. I've got to kind of have a network of folks, which is already a bit of a breakdown in the system. Whereas if I could transition them to one person who could accept those patients, it would make the whole process a lot easier. So I think that's kind of the million-dollar question, is how we streamline that process and how we can make that more effective and efficient for patients and their families. But I think education and communication is the most important part of that.
I am your co-host, Dr. Arthi Hannallah, and I have with me Dr. Niccolo Passoni. We are the Pediatric Urology co-hosts for all the BackTable episodes so far.
Hello, everybody. Today, we are hosting a session to talk about kidney stones in the pediatric population. We have two guests, and I have the privilege and honor of introducing Nicholas Kavoussi. He trained with Arthi and I when we were residents at UT Southwestern down in Dallas. And now he is an assistant professor of urology at Vanderbilt. He specializes in minimally invasive surgery, whether it's robotic or endourology, and he also has a passion for research.
Thank you. That's enough. It's enough. Thank you for having me. I'm happy to be here to talk about this topic with you all. So thank you.
Great. We also have Dr. Scott Sparks. Dr. Sparks is an assistant professor of urology at the Division of Pediatric Urology at Children's Hospital, Los Angeles. Originally from Texas, Dr. Sparks trained at the Baylor College of Medicine for medical school, followed by residency at the University of West Virginia and a fellowship in pediatric urology at UC San Diego. He briefly was at Children's National Medical Center in DC and has since been in Los Angeles at CHLA and USC. He is the surgical director of the Comprehensive Stone Program and is the fellowship director of the Pediatric Urology Fellowship at CHLA and was my former fellowship director. Thank you for coming on with us.
Yeah, thanks for having me. Appreciate it.
Thank you, everybody, for being here tonight. So the scope of this podcast episode is to discuss stones in pediatric patients, especially in this complex one. We're not talking about your straightforward bread and butter uroscopy in a 17-year-old, almost adult patient, but more those complex patients. Those are medically complex for their neurological status. They might be quadriplegic or have spina bifida. They might be severely contracted, have a lot of comorbidities. There might be G-tube dependent, trach dependent. So those patients are the ones that tend to present with large stone burden, might require PCNL, and that is not a straightforward PCNL. So I'm going to start by asking Dr. Sparks, what is your approach when you see one of these patients in clinic that might have a staghorn stone in the kidney with scoliosis, and it would be very, very hard to perk?
Yeah, obviously we all recognize that this is a particularly challenging population for many reasons, both anatomically complex as well as medically complex, and then surgical approach, which kind of goes hand in hand with all of that stuff. I think, the most important thing to assess right off the bat is how much we think this patient is going to tolerate and how it is going to be best to approach the stone, right? Obviously, we always want to assess the stone burden. As part of that, obviously, we have imaging. As everyone knows, in peds, we tend to, stay away from ionizing radiation. So most of our patients are going to have ultrasounds as their primary imaging modality. I will say, if I am considering doing a perk, I'm almost always going to get a low-dose CT scan. I think it helps me to better to delineate the actual burden, which can be a little bit tough on ultrasound, but also to kind of get a better view of their anatomy so that I can kind of figure out the best approach, which calyx to approach, et cetera. I don't know if Nick has any other things to add about that.
No, I think planning is really what it's about. We've discussed and published a bit on this sort of idea of an adaptive PCNL, where, you really have to adapt to the patient and their anatomy, their stone burden in terms of positioning, in terms of how you're going to get access, whether it be ultrasound, whether it be fluoro, whether you have IR assist you with CT guided access preoperatively or something like that. So, I think in these extremely challenging cases you're discussing or you're bringing up, Nico, you really have to be adaptable and get creative sometimes with how you treat these patients.
Oh, sorry. I will say in my experience, in the peds world, we don't do quite as many PCNLs. And I learned a long time ago that I'm not the one to get access in these patients. compared to probably you, I do a lot fewer PCNLs per year, and my skills at getting access, especially in someone who has complex anatomy, are just not there anymore. So I'm always going to rely on my IR colleagues. I'm very fortunate in that I have some really great IR colleagues, and I have a really great relationship with those guys, and they get me much better access than I could ever get. And we always have a very thorough discussion before about which calyx I want as my primary option. And if they're unable to get access there, kind of what are my second and third options. So I would say for folks out there who don't get their own access like me, obviously having very open communication with your IR folks beforehand is key. It makes all the difference in the world.
I think you bring up such an important point about having almost an algorithm of what you want to do in terms of getting your access in these complex patients, notably if you're going to involve IR. Can you walk us through kind of more so how you would approach getting access with IR? Is this something you do, the day before, at the time of the procedure? What has been your experience, Scott? And then Nick, what has been sort of your approach to this, especially when you're getting your own access?
Yeah, I mean, we've tried it a few different ways. When I got to CHLA, I was very adamant that I wanted to get it on the day of and basically have IR come to the OR with us. We did that. It's quite logistically challenging. And it ended up, for lack of a better word, wasting a lot of time in the operating room. Then we tried sort of a hybrid where the patient would get their perk on the day of, but then they would get their perk in IR. They would stay under anesthesia and then be transported up to the OR. That was a major disaster. And then now we're kind of back to the more old school way of doing it, which is they come in the day before, they get their perk access, and then the next day I take them for their actual PCNL.
I'm going to jump on this question because where I did my fellowship training in Dallas, we had the luck of having the adult faculty, was Dr. Antonelli or Dr. Pearl, come over to the pediatric hospital and getting access for us the day off. I feel like not all pediatric hospital have that luxury. It's always hard sometimes to coordinate schedules and whatnot. I was going to ask Nick if often you've been called by the pediatric colleagues at Vanderbilt to help in that case, or you, Scott, if you had your USC partners come over, and if that's the case, how does that work out? Is that something that folks can try at home, or is probably better to go the IR route?
Well, you should probably try it at the hospital, not at home. I've been called over a few times recently. In recent memory, I can think to sort of do some perks with the pediatric faculty. And I think the overall, I don't really have a different approach or anything. I sort of do it the way I do it in adults. I think 90% of my perks, I try to do supine, and I'll do prone if I'm doing bilateral. It's a big stag that I need access to multiple calyces. I ultrasound all patients to see if I get ultrasound access. I like it even if I'm going to go fluoro, just because it allows me to see if there's any anatomy that might be in the way, bowel, spleen, liver, pleura, anything like that. I always look with an ultrasound probe, and I do that. I do the same thing with the pediatric patients as well.
And Nick, has that been your experience for most age groups when it comes to the pediatric population, or have you had to adapt based off of their age or their size?
I think access, I haven't really had to adapt or change in terms of what sheath I'm going to use or things like that. That's been more of a consideration, and that's something I've had to adjust to, especially in much younger, smaller kids.
You brought up an interesting concept of supine PCNL in particular. With most of our complex stone patients, we talked briefly already about the issues that they have with contractures, the nuances of positioning, potentially even the issues associated with, having them prone from an anesthetic standpoint. For both of y'all, tell us more about your experience with non-prone, so supine PCNLs, and, how that's been in terms of applicability and, reproducibility in this very complex patient population.
I mean, I can start off. My answer is very brief. I haven't had any experience with supine PCNLs. I agree. I think it sounds really tailor-made for a lot of these kids who are contracted, and it's hard for them to be prone. I've actually approached a few of my adult colleagues over at USC about coming over to help me do my first one or two supine PCNLs. Just to close the loop on the other question about having my adult colleagues come over, at least where I'm at, it's quite difficult. It's, we're pretty geographically separated. So it's not a matter of just like popping over to like help us get access. It ends up being a full day for them. So, but if it was something like a supine PCNL taking me through my first few cases, that's a more reasonable ask for them as opposed to just asking them to come over and get access. But I agree. I think that supine PCNL is probably the way a lot of this is headed. Plus, then obviously it gives you the option of going up from above and below a little bit easier than if you're prone. I think we've all been in those cases trying to go from below on somebody who's prone, and it's not the easiest thing. It's obviously doable, but it's a little bit more challenging. So having that flexibility, I think, is really, really attractive.
I agree. I think from what you said, anesthesiology, the anesthesiologists really like it, right? Because it's easier and they're more comfortable with the tube, and especially these challenging kids who have simultaneous airway concerns and trachs and whatnot. It's a lot easier to do. And I think you get the benefit of some gravity drainage of these stones as well with a lot of the way these kidneys face, and it's faster. You don't have to worry about position as much. I'm less worried about nerve injury and pressure injury and things like that. So it's a little bit more manageable. So I think that's those things have really pushed me more towards doing more supine when I can. And like you said, access from below and having, access from below you're comfortable with, and getting your ureteroscope in there if you need to or something like that is something you can't really ever go wrong with.
And have there ever been circumstances for you where a supine approach, besides, the patient just can't tolerate anesthesia or a physical issue, what are sort of instances in your experience so far, Nick, where you've not found a supine PCNL to be feasible in some of these more complex patients? And have you had to consider doing stage ureteroscopies or, other methods?
Yeah, I mean, so so supine versus prone, I think really depends on whether my ability, I feel comfortable with getting to the kidney around rib, whatnot. I think what you're alluding to, and there's a couple reasons why I might do stage ureteroscopy instead. One is that they have really significant comorbidities or some sort of bleeding concern or something like that I wouldn't want to prick into the kidney. The second is where I really feel like there's absolutely no way that I'd be able to access the kidney. And in those patients, oftentimes I will talk to IR and I'll say, hey, do you think you can do it under CT? I'm not confident I can do it in the operating room. And sometimes I'll get CT guided access beforehand for me. So I think that if I'm going to put a patient under surgery and I want to get them stone free, I'll try to give them the surgery that they need, whether it be percutaneous, and try to get access with my colleagues in IR if we need to, if it's really that difficult to approach the kidney. The stage ureteroscopy I reserve for people who I think wouldn't tolerate a PCNL from bleeding concerns or other comorbidities or things like that. They're higher risk, and I wouldn't want to put them through a more morbid surgery if I could avoid it.
I mean, luckily, I think those are relatively rare circumstances, right? I think that I definitely had one this year where one of my patients had a bleeding disorder, plus she had pretty severe scoliosis, and it was going to be very challenging to access this kidney. So we ultimately opted to do stage ureteroscopies. Luckily, that's the first time in a while that I can remember, having to actively avoid a perc. I think that luckily, at least for me, my IR colleagues are really talented at getting me access almost every time. So generally, if I'm doing it staged, it's because of the patient's comorbidities. And like I said, even though a lot of the patients that we have quite significant comorbidities, most of the time it doesn't preclude a PCNL.
I think just something with our patient population to also keep in mind is, in addition to their stone burden, is also stool burden. When they're contractured and they have such significant scoliosis, or, depending on their body habitus, especially spina bifida patients where they're very centrally endowed, I think one of the issues can certainly be how much the colon and the fecal burden can have an impact on being able to get, not necessarily access, but just, being mindful about your access as well. And so what have been sort of tips and tricks for y'all when it comes to these patients who are, very impacted fecally, or, have some sort of complex reconstructive surgeries done already that has made their intra-abdominal anatomy even more complex?
I can't remember a patient where stool burden was a factor when it comes to PCNL. I can definitely tell you stool burden has been a factor with cystoscopy and ureteroscopy. I've actually had a real difficult time getting into some of these kids' bladders, and one time even I had to abort to have them do like a really good bowel clean out, and then I brought them back and everything was like super easy. But I've not had an issue where I had to modify my plan based on stool burden when it comes to PCNL. Obviously, if they've had other complex reconstructive procedures, that's a different story. I mean, that's obviously one of our one of the things that we think about in terms of surgical planning, how we're going to get access based on what might be in the way. And like I said, I feel like a broken record. I rely very heavily on my IR colleagues with that to decide if they feel like it's appropriate to try to go through a patient with a prior surgery, et cetera.
So talking about complex patient, spina bifida, oftentimes we see stones in these kids. Historically, patients with spina bifida used to succumb due to renal disease until we figured out how to manage their bladders. But there are patients that have a higher risk of chronic kidney disease in the long term. So there's always a virtual risk. The more perks you do, the more damage you do to the kidney. This might be a question more for Scott than for Nick. Is that something you disclose to your patients? And how do you factor that when you are medically managing these patients, following up for recurrent stone patients? How aggressive do you get in chasing all those fragments, first of all? And then let's say 6 months later, you see a 3 millimeter stone. How comfortable do you watch it? How big do you let it get before you intervene? Again.
That's hard. And that's when you have to really, rely on really good informed consent and good conversations with your patients and their families. I think one of the biggest conditions you're kind of alluding to is like cystinuria, right? We know that those patients are going to have progressively poor kidney function. And you're right. I think that in general, the fewer times you can perk through their parenchyma, the better. I think you have to then, however, really weigh the benefit of what's worse, like having big stones in your renal pelvis that are getting infected versus perking through the parenchyma. I generally feel that like a perk probably does way less damage. And so I'm more likely to stay relatively surgically aggressive with those patients. That being said, I really favor very close follow-up and obviously, if it's reasonable, more frequent ureteroscopic stone removal in those patients. So really not letting their stones get very big, especially with the cystodurics. I try to really kind of stick on them like glue and have them follow up very, very frequently. So I'm not hesitant to do PCNLs in those patients, but those are also the patients where I'm way more anal about getting all of the stone when I'm in there. Because I know that they're going to be back, right? I know that they're going to have more surgeries. And so the more stone free that I can get them, obviously the less often I'm going to have to be back there. And so the more I feel like I'm protecting their parenchyma. But I feel like it's always a balance that you have to strike. And I don't know that there's a hard and fast rule, right? I think that's going to be very different for different patients, and it's going to be very different for different families and different diseases. So it really involves having a very clear conversation with the family. And in those cases, especially when you're talking about a patient with high risk of progression to chronic kidney disease or who already has chronic kidney disease, I think it's very important to have your nephrologist around as well to kind of facilitate some of those conversations as well. For us, I also rely very heavily on my nephrology colleague who kind of co-directs the stone center with me. And so all of our complex stone patients, like we see together as a unit. And I think it's made me a better surgeon having her around. And I think it's made me more conscientious about stuff like that. So I think it's just keeping lines of communication open. I feel like it's always an easy thing to say and it's hard to do. The more you can communicate, the more you can have honest conversations with the families and the other members of the team, kind of the better off you're going to be when you're managing a lot of these really complex, high risk of recurrence patients.
I think the concept of multidisciplinary care is so critical in the population of patients who have genetic conditions, especially like you mentioned, cystinuria, the dent disease patients. All of those patients have more rare conditions that we have so many different ways of approaching the ability to prevent them from having these stone recurrences. As they kind of go into adulthood, Nick, what has been your experience, for some of these patients who, beyond just having complex, anatomy, but the patients who have these pre-existing genetic conditions, what is your threshold in terms of intervention versus, watchful waiting or, what have you when it comes to patients with maintained stone disease as they go into adulthood?
Yeah, it's a balance because a lot of these people, their stone disease has become part of their, something that defines them in a lot of ways. And there's some trauma oftentimes associated with the surgeries they've been through. There's some anxiety associated with their disease and everything like that. And I think it's really about forming that partnership and sort of working together with them and seeing when they want to go. I do my best to stay on top of these people as well and make sure they have pretty routine, regular follow-up in case they get into trouble. And when they do, I try to move quickly for them, because I don't think they have normal kidneys. I don't think they have kidneys that can take as much obstruction as other kidneys and recover. So I'm a bit more aggressive, but it's really in the acute episodes, but it's really dependent on the patient and sort of what their experience is and what their expectations are and what they want. Because a lot of them, by the time they get to me, they've been dealing with this for years and years and years, and they know their body, they know their kidneys, they know their stones, they know what's going on with them. I try to form more of a partnership with them rather than anything else.
Have you found that patient-directed or shared decision-making when it comes to complex stone management has led to a decrease in the number of stone interventions that they've had? Or what has been your sort of outcomes, like gestalt, in this patient population when you're doing shared decision-making?
Yeah, it's tough to say, and I feel like I don't know if I have a great sort of overall sort of message about what we're seeing with shared decision making. I think it's really different and dependent on the patients. I think the one thing I am trying, because the one thing I think that, and I don't know if I know on the outline there is an order to things. The one thing I think that always comes up with these patients from their experiences, the stent management afterwards, and how traumatic that was for them and what that experience was like and everything. So I think in some of these patients, I try to do stent free. If we're going to intervene, I talk to them about that. I don't know. I'm not familiar as much with the pediatric population, how possible that is. And when they get adults, the ureters get a little bit bigger. So sometimes it's easier. So, I mean, that's one thing I try to do for these patients, or try some of the novel stents, the smaller ones, the silicone stents, and all these sorts of things to try to see if I can work with them with that. That doesn't answer your question at all, but that's one, I think, particularly in that patient population, I have to be a little bit more careful with the stent management and stent planning, things like that. Also, I see plenty of people who are 17, 18, who go from a pediatric to an adult clinic, and it's a very different feel, a very different vibe for them, right? And most of my patients, if they don't have a string, I pull it under cystoscopically in clinic. And the 18-year-olds don't tolerate that, and they're not used to that, So it's a very different, some of the workflows that we have built in to the adult clinical practice just don't work well for these kids who just transition from the pediatric to adult clinic. And that's something else that I try to be thoughtful about, but it can be, again, it's very patient dependent, and it can be tricky sometimes to navigate those situations.
I think you bring up such a good point when you were talking before about trauma. I think that if you talk to these patients, right, like these are particularly traumatic surgeries for them. My sense is it's mostly related to stents. I really do my best to make that as traumatic as possible, knowing that that's kind of an almost impossible task. There are a few things I do. I mean, number one, I try to use a nice soft stent. I anecdotally, I think that makes a difference. I try to make sure the stent is appropriately sized. I'm definitely not afraid to burn a stent if I think it's too long. I'll put a shorter stent in. I mean, obviously, I think that makes a big difference. And obviously trying to shorten the duration of leaving a stent in place. I almost never leave a string. I have had a lot of patients complain about strings, especially male patients. So my pediatric cohort, like for boys, almost never get strings. Girls, I kind of talk to them beforehand. If they're a little older, they're sometimes more amenable to it. But I think we can't kind of underestimate the trauma that these procedures inflict on these patients. And, I think about stone disease as chronic disease, right? Like this is something that they're going to have for their entire life. So I really try my best, and I know that I'm sometimes working uphill with this, but I try my best to make their early experiences with surgery as pleasant as possible. I think that, again, you're going to succeed with that sometimes and other times you're not. But I think just being very thoughtful with how you approach it, and I think just being very honest beforehand with the patients. I think that the more upfront you are and the better you set their expectations, the better it tends to be. So I think that I used to poo-poo that a little bit, but I really have come around the past like 5 or 6 years to the fact that we are really causing trauma to our patients, and we need to do everything that we can to minimize that, because they are going to go on to have these surgeries later in life, and this is going to keep cropping up. So the better we can make it for them when they're young, the better it'll be when they're older. But it's certainly, there's no good answer, I think. You talked about trying to go stentless. I do go stentless in very select patients. Obviously, I'm a little bit more concerned just given the size of their ureters, and sometimes I have to pre-stent because I just physically can't get access ureteroscopically. But like I said, I try to do my best with that, and I try to minimize the length of time that stents are in as much as possible.
I think both of y'all have hit one of the most critical elements, I think, of a combination of shared decision-making and multidisciplinary care in this specific patient population, which is to reduce as much trauma as possible. And, risk reduction is significantly impacted by preoperative counseling and, most importantly, managing and setting expectations. One of the passion projects of Dr. Sparks that I remember very well was, he wanted to see if there could be a role of a psychologist in a multidisciplinary stone clinic. And I think someone helped you with that research project.
I can't remember who that was.
I don't know either. But the interesting thing in that study was that we found that caregivers or parents were more likely to be concerned about the patient's pain, whereas the patient themselves are more likely to be concerned about needing to go back for recurrent procedures. And so the expectation of what the outcome is going to be for the patient and for caregivers, and in your case, Nick, especially when it comes to these patients as they're transitioning into adulthood, and they may have a caregiver that's still kind of involved, may vary. And that in itself can have a significant impact on the ability to take these patients back or not. And most importantly, I think counseling them on what some of the major risks are of an operation like this.
Yeah, I think I still believe that a psychologist would be super beneficial in this population, especially in peds. One of the things that we found in that study was that most patients didn't think they would need a psychologist. And so it really kind of like threw a wrench in my plans temporarily, but I still have plans to try to get psychological support for our stone clinic. I just think that it's a really neglected part of what we do. I think as surgeons in general, we kind of neglect that, but especially for these patients who are going to need oftentimes surgery after surgery after surgery, I think that having some psychological support can really help them to prepare for it and then cope with it afterwards. I have a strong suspicion that if we give them better coping strategies, that they will be more likely to be adherent to our medical management as well. I think that part of patients losing their ability to stay compliant is sometimes a sense of hopelessness and sometimes a sense of resignation. And I think that having strong psychological support might really benefit them long term in terms of reducing stone recurrence, but we'll see. TBD.
Just to kind of wrap up this section about surgical risk reduction, for both of y'all, what has been more of your contemporary practice in management of postoperative pain and symptom control, not just immediately postoperatively, but even, 2-3 weeks ahead? I think we've all been there when we've gotten called about patients who either just had a stent removed or they had a, PCNL or ureteroscopy a month ago, and they're still complaining of pain. In this specific patient population, patients who have recurrent stone disease, known either genetic or, an identifiable risk factor for stone recurrence and progression. What has been your contemporary approach for pain management? Maybe we'll start with Nick.
So you mean like acutely, or are you talking about 3 weeks out? Or so I'll say this I'll say that we've developed some ERAS protocols for uroscopy and PCNL that really sort of, I think, came out of us trying to move away from opioids over the past 5+ years or so. And it's pretty standardized for most patients. That includes, the usual stuff, the Tylenol, ibuprofen, and then some stent-specific medications, an alpha blocker, something for the bladder spasms and whatnot. And in our initial studies, we really found no difference in this sort of medication regimen compared to previous ones that involved opioids. I will say that intraoperatively in the anesthesia unit, they're getting a little bit more stuff as well. And I don't have the list off the top of my head of all that they're getting. I think to answer your question, I think contemporary practice moving away from opioids and trying a multimodal pain approach to try to get people through the postoperative period.
I would second all of that. I would say the other thing that we've learned more about is our surgical technique can really dictate their pain postoperatively as well, right? So really making sure that we're keeping intrarenal pressures as low as we can. We know that that's a strong correlator with post-op pain, infection, et cetera. So, trying to irrigate less or using access sheaths to make sure that we don't build up a ton of pressure inside the kidney, trying to make sure that we're not just lasering like crazy so that the kidney doesn't just get super hot from the temperature of the laser. I think that all of these things are things that all of us have started to do. And now we've just kind of incorporated them to the point where it's second nature a lot of the times. But I think that my experience, I'm really far out from residency now. My experience is that, I think patients have less pain after stone surgery than they used to. I remember very vivid. And I don't think it's just, we've learned that they don't need as many opioids and we've learned how to, I really think that they have less pain because of ways that we have modified our surgical technique. And I think that that's all a super important factor. And I try to remind my residents and my fellows all the time, right? Like, try to irrigate as little as you can, try to laser judiciously, try to take breaks from lasering, try to, all of these things. And I think it makes just a massive difference when it comes to their post-op pain control.
Yeah, you're absolutely right. You're absolutely right about that. I think we definitely make intraoperative decisions for post-operative pain control.
And sometimes that involves kind of stopping earlier than you might like to, right? Like I do that all the time where things are going okay, but I'm like, we've been in here a really long time and we're just going to pause for today because I feel like we're kind of reaching the point of diminishing returns. So I think that we shouldn't discount that. I mean, those are definitely things that we do to mitigate pain postoperatively. And I think they're quite successful for a lot of patients.
That's a good point. It's a good segue to move on to the next section of our podcast about technology and how things are changing quickly in the stone world. I still remember using the holmium laser. Now, being in a pediatric hospital, we have less access to technology, rightfully so, because we do less stones than a big adult hospital. So all the residents come and talk to me about all the new lasers they've tried, the MOSIS, the thulium lasers. And there are some drawbacks from my understanding. I'm not a stone expert. That's why we invited you two on the podcast. And by my understanding, the thulium laser carries more energy and more heat in the kidney. And then, we also have novel ureteroscopes that have pressure sensors, because I feel like the research is moving, the technology is moving more towards the importance of the pressure irrigations, which can have an impact on pain, but as well as infection. So I would like you to comment on, if possible, have a nice fireside chat on novel lasers and how they can be applied in a pediatric patient, which is smaller, as well as pressures and considerations, whether you should be using handheld irrigation, like we were trying to use Southwestern, or maybe a pressure bag, or a combo.
I mean, I feel like I can answer this very, very quickly because I still use a holmium laser. That's basically all I have access to. I have tried a couple of the other lasers. Certainly, I would like to try them a bit more, but my hospital can get me a holmium on a regular basis, so that's what I use. I still find it adequate for the most part. When it comes to pressure sensors, I've tested out a couple of the scopes that do have pressure monitoring systems. I don't have them, routinely at my hospital. I wish I did. I would like to have that data. I feel like if I don't have the data, I can't really make meaningful adjustments other than, quote, I'm trying to reduce the pressure. If I actually had that data, I could actually make very meaningful adjustments to do that. But I don't have access to a lot of that newer technology either. And I think you brought up a good point, Nico. Like a lot of people at children's hospitals don't, because we don't do the volume. So we'll get that stuff later down the road.
I have some of that stuff and I can talk about it. So I think that you talked about holmium. MOSIS is pulse modulation of holmium laser. That it seems to be a little bit less retropulsion and better energy delivery to stone for fragmentation. You have the thulium laser, which you talked about, which is a continuous laser. So you don't have the pulses anymore. So you don't have you don't really have any retropulsion. It works really well, you're correct in that the issue is when it first came out is that none of us knew what we were doing. And you could, if you looked at the wattage really in terms of how much energy you're delivering over time, you get up to like 60 more or above watts, which is insane in the kidney, right? So I think if you use it safely and are thoughtful about your settings, it's a safe and good tool. The pressure sensing, I don't think so. No one has really published, and we don't have a really good understanding of what pressure sensors will do and what they'll like, what information we really get and how those associate with outcomes. We don't really know yet. One thing that you didn't talk about, I don't know if we're going to talk about it, that's really been impactful and changed my practice are the suction sheaths fans. And I brought them over to the Children's Hospital to use them in the past. I'm tackling cases that used to be PCNLs for me ureteroscopically because of these sheaths. And I think the suction allows for you to keep pressures lower, which helps with pain, like we talked about, which helps with infection, I think, and enables you to tackle, I think, more difficult and complex stones than you would typically. So that's one. I think a laser is a laser. There's all sorts of lasers you can use. I think if you're comfortable with the laser you use, then use that one. The suction sheaths, I think, has really changed my approach to stone care for many patients.
Yeah, I've really been wanting to try a suction sheath. I will say the question that I've always had, which is, and I won't know until I really try it, you might be able to answer this, is my sense is that in a smaller kidney, the suction might be more of a problem. You've got less volume of fluid in there to begin with. And so is it more difficult to balance the suction with the inflow and prevent it from just fully decompressing your kidney while you're trying to work? I mean, I'm assuming there are workarounds with that, but I'm very excited to try that sheath.
Yeah, no, there are workarounds, absolutely. And you do kind of in some kidneys, depending on the anatomy and where your sheath is and stuff like that, you really have to sort of figure out where the balance is going to be, how you're going to modulate the pressure, both from the suction standpoint and your irrigation pressure, and toggling it on and off and whatnot. It's really I think it's really changed how I treat some of these patients for sure.
They're game changers, especially for those kids that stones are softer, maybe infectious related. I think the only limiting factor that I've encountered is the size, but I feel like oftentimes in children's, like Scott mentioned earlier, you have to pre-stent, but once you pre-stent on the suction sheets, it turns cases that could have been PCNLs easily into uroscopy. They're a phenomenal addition. And I've also heard of partners using that as mini PCNLs, because I feel like those sheets are 14, 16 French, and adding that suction that, because like when you do a 20, 24 French axis sheet, like the stones flow out. If you're trying to be more conservative, like Nick mentioned earlier, you have like a 7-year-old child, you don't want to perk them with a 24 French axis sheet, you want something smaller. I think those suction axis sheets really make a difference. And I've been trained in the adult world using regular nephroscopes. So mini PCNLs is not really something I dabble in, especially the micro PCNL. I've never heard anybody doing micro, which I think it's like 4.8 French. I don't know, Nick, if you often downsize your nephroscope, or Scott, if you ever do mini, I'm going to talk about micro PCNLs in your world, or if that's something where us pediatric specialists can improve.
I mean, I use a 12 French sheath when I do my PCNLs. I can't remember the last time I used a bigger one, but I also don't use a smaller one. I use a 12 French sheath with a 9.5 cystoscope. That's what I have, and that's what I use, and I think it works quite well. I certainly think that, having a nephroscope, the different configuration of the fluid intake, or the import and the suction, would be nice, but I don't have that, so I use my cystoscope, and I'm able to do a pretty darn good job with it, I think. But I use a 12-foot sheath.
So you rely on lasers to break up your stone. You don't use any other energy devices for that. Pneumatic.
I do have access to a cyber wand, but I don't use it because it doesn't fit through my scope.
What age cutoff do you use? Or do you, like your teens, do you still use your 12 French sheath?
I do, yeah.
What about you, Nick? Do you ever go smaller, or do you stick to 20, 24 French?
Oh, I go smaller sometimes. So in the adult population, I usually do a 22, and I feel like that for me enables me to feel comfortable getting patients stone-free as efficiently as possible and get them off the table. There's been a bunch of literature, mini versus standard PCNL in the adult world. And I think there's some decent evidence that you may have a decrease in blood loss for mini, which makes sense. There's some concern, as we talked about earlier, about renal dysfunction for bigger holes you put in the kidney, which I think is a good point, a good thought. The concern with the mini has always been pressure, has been pilovenous backflow, has been infection. Now, the Edge Group had an abstract at AUA comparing in a large multi-institutional study looking at in adults standard versus mini, and really didn't find too big of a difference between the two techniques. Doesn't mean there obviously can't be some, and I'm sure that further work will show there are some. So 22 French for the most part. If it's an isolated, maybe 1.5 centimeter stone or something in a single calyx aldo mini, in the pediatric population, I don't feel comfortable in the pubescent population dilating up to 22 French. I think it's really big for those kidneys. So I tend to do those more as a mini perk. And there are 12 French suction sheaths that you can put in percutaneously that I've tried, and I like those a lot for that. And then I use laser. They have small lithotrite probes too, but I've had a lot of trouble with them. I think they block up a lot and they bend and they have issues and stuff like that. So I don't really like using those.
Just to kind of piggyback and wrap up this section here, one of the most challenging population of patients that end up going into adulthood now, especially now more and more, are patients who've had complex lower tract and bladder surgeries. So our augmented patients, our patients with catheterizable channels, bladder neck closures or reconstructions. And so many times our patient population, especially if they have recurrent bladder stones, we're not always able to access from below. And we're constantly having to tiptoe either around using delicately a ureteroscope to go through their catheterizable channel, or succumbing them to recurrent percutaneous procedures suprapubically to get into their bladders, which over time can get progressively more difficult as more and more scar tissue builds up. So, Nick, where do you see the utility or the role of these suction sheaths or some of the more novel technology that's coming out in ureteroscopic surgery in this type of patient population?
Like bladder
and Scott,
stones?
do you see that happening? Yeah.
Yeah. I mean, I think so. I don't know. I treat the catheterizable channels as sacred. I never go through them. I don't want to. That's their lifeline. That's something that has become such a part of their life. I feel like, so I'm never too worried about perking into a bladder. And I don't know if there's a role for the suction sheaths. I think 22 French no bladders is something I'm not too worried about. And they all seem to heal up pretty quickly. And I mean, those patients are the ones, though, that you really need to stay on post-operatively, make sure they're irrigating their bladders. And because those, I think, are more preventable with education and regular bladder irrigations. So I don't know if Dr. Sparks has other thoughts.
I unfortunately see quite a few of these. Also, try to avoid the catheterizable channel. I don't maybe treat it as sacredly. I do use it on occasion, but if I use it, I use a ureteroscope, and I'm always very aware of what I'm doing. The good news is a lot of these patients you can still access from below, unless they've had a really aggressive bladder neck reconstruction or a bladder neck closure. A lot of the times you can access from below. And again, as long as you're not being super aggressive, I don't feel uncomfortable doing that. That being said, I'm also not hesitant to perk these patients. I think that, you do what you need to do for that patient in that moment. And I think that that's going to be different. I can remember I have one patient who I've literally done all three things on. Once I went through his catheterizable channel, once I went through his native urethra, and then the most recent I perked into his bladder. I was going to do an open surgery into his bladder, and then I thought better of it at the end and just perked into it, and it worked really great. So I think you just have to be ready. You have to be flexible, and you have to take each patient and each situation kind of as a one-off and do what that particular situation requires. I think that's a common theme that we've kind of talked about with stone patients it's really hard to have a very definite algorithm because every patient presents with their own kind of unique issues, whether they're anatomic or medical or stone configuration. So you just got to be on your toes. That's one of the best things about these procedures, though, is that they're always going to keep you on your toes. That's for sure. No two cases are exactly alike.
I do appreciate Nick's respect and reverence for the comment channel.
Yes. Thank you.
But going back to perking, because this podcast is also meant for a broad general urologist audience, any concerns about perking into an augmented bladder? This is both a question for both of you. Do you always try to go through the detrusor, or you also feeling, courageous and perking through the bowel side? And if you go through the bowel, any specific recommendation when you take your port out?
I mean, I think in a perfect world, we would always perk through the detrusor. We certainly don't live in a perfect world. And I can tell you, I have perked through the augment section. The first time I did it on accident. And I just basically did a purse string when I kind of left. And that's served me well. Like I said, in a perfect world, I would like to always stay in the detrusor. But with the configuration of the augment, you don't always get that luxury. But often you can. I don't know if you have any different experience, Nick.
No, I don't. I agree. I think that should be more favorable. But I think you can get away with going through the augment as well, as long as you don't do anything too traumatic.
Or the mesenteric.
Right.
And I mean, obviously, I think if...
That'd be hard to do.
Yeah. But on times where I know I'm going through the augment, I'm definitely going to leave those guys with a catheter for quite a while to keep them fully decompressed.
Yeah.
But I think Nick brought up a great point. All these stones in the bladder, unless they have upper tract nephrolithitis, it's all about prevention, about irrigation, proper management. I don't know if I remember reading somewhere in the past using mucolytics to try and prevent mucus collection because that's where most stones come from. But I feel like the key point is like if your patient keeps getting bladder stones, make sure they're irrigating, and not with 50 or 60 cc's, 120, enough to mobilize the mucus and prevent from sedimenting it and drain their bladder. Catheters at night. That's like the one-on-one on stone prevention in the bladder. I feel like that's what I use in my practice.
Any of my patients that are augmented that come with bladder stones, they automatically get another teaching session about catheterizing and irrigating. It's just a good refresher. That's ultimately what we're trying to do is we need them to irrigate a bit more efficiently, whether that's with more fluid or whatnot more often, but we need to get them kind of like primed and ready to go. So
it can be tough. I'm sitting here thinking about how many months I've been wearing my monthly contact lenses in my eyes right now. So I get compliance and challenges with compliance and stuff like that. So, I think re-education is always helpful.
So just to kind of summarize, both of you guys, we wanted to bring here to address sort of how to bridge these patients moving forward into the rest of their adult life. As we see more and more patients are being diagnosed with kidney stones, we're identifying more and more genetic and pre-existing conditions that are now identifiable risk factors with stones in children. And so as we are seeing a rising incidence of kidney stones in this specific patient population, what do y'all feel are sort of the key takeaways when it comes to helping these patients transition from being at a children's hospital and going into adulthood, whether it's sort of patient education, caregiver involvement, understanding of their diagnoses? What's sort of your parting visit for you, Scott? And sort of what are, from your perspective, Nick, what are sort of things that you go through as a checklist for these specific patient populations?
This is like the $1 million question, right? I mean, this is the question that's on every physician's mind, not just with stone patients, right? Like, how do we effectively and efficiently transfer these patients to the adult world? And I would be lying if I say I had like the answer. Nobody has the answer. I think the best you can do is try to prepare them as much as possible. Try to get them medically kind of like tucked away as much as possible before you transition them over. Sometimes that's easier than it is at other times. Trying to make sure that you've done your best job at educating those patients about, their disease, and in this case, stone disease, as well as their caregivers, because many of these patients are going to have caregivers with them for an indefinite amount of time. But so trying to educate them and their caregivers, and then trying to educate them about what to expect when they transition over to the adult world, because as Nick alluded to earlier, we do kind of deal with things a little bit differently in peds than you guys do on the adult side. We literally never scope anybody in clinic. We don't do anything like that. And so I try to at least give them kind of a heads up that, things might work a little bit differently, and so that they're a little bit prepared. But I think the challenge that I face, I'll tell you, is that, with the way medicine in the United States is, right? Like, I can't just say, okay, I'm going to take all of my stone patients and send them to this person just because this guy's insurance might let me send them there. This girl's insurance might let me send her there. And so I've got to kind of have a network of folks, which is already a bit of a breakdown in the system. Whereas if I could transition them to one person who could accept those patients, it would make the whole process a lot easier. So I think that's kind of the $1 million question, is how we streamline that process and how we can make that more effective and efficient for patients and their families. But I think education and communication is the most important part of that.
Yeah, I agree with all that. I think recognizing that the extremes of this patient population is the one who has the overbearing family who makes all the decisions for them, and they really can't make decisions for themselves because of that, to the other extreme where they don't have that support and they don't know what's going on and they disappear, they fall off the cliff. Recognizing that as they move into the adult world, and trying to see what we can do as part of their care team to give them the support that they need and empower them to make decisions for their own health care.
I was going to say transition is a very delicate aspect of any pediatric specialty, especially urology, whether it's like stone disease and reconstructive urology, spina bifida, extravascular patients. And I feel like it's not just a matter of like finding a provider, but also finding a provider that's comfortable taking on those patients. Fortunately, I feel like stone disease is fairly common among the adult world, but for those more complex patients, spina bifida patients, contracted patients, genetic patients, it's always important to try and find an adult specialist like Nick here, who has expertise in treating these patients, and not just your general urologist that, might do one PCNL a month, or like your straightforward stone case. But oftentimes I feel like, even being in a big city like Houston, we have a hard time with insurance coverage. And a lot of these patients then end up falling, as Nick said, off the radar for a long time, either for a lack of want or need, and then showing up with very, very tough stones to crack.
I think you bring up a good point, though, which is that we are somewhat fortunate in the world of stones that it's a little bit easier to transition our patients than some of the complex recon patients that we have. At least with stones, like you said, there are a lot more adult urologists who are willing and comfortable taking those patients, as opposed to patients who have had really complex pediatric bladder reconstructions. It's a bigger ask. So I do think that even though it's challenging for us, we have a slightly easier task to transition these patients, just given the fact that stones are so common and most urologists are quite comfortable dealing with them. So it's an easier thing. But I also think, how I kind of talked about the beginning, like when I first start having conversations with patients that present with stones, my very first visit, I tell them that it's a chronic condition. And I try to really make sure that they understand that this is their whole life. And so my hope is that sinks in, and then by the time they're ready to transition, they understand why they need to transition. Even if they're doing okay at that moment, like why it's important that they follow up with someone. So I think that, again, it's all about, setting those expectations, making sure that the patient is educated about it, doing your best to set that up way ahead of time.
That's very, very well said on both y'all's parts. This is always going to be an issue for us as pediatric urologists, as these patients grow up into adulthood. We don't want them to be defined by their diagnoses, sort of as Nick was alluding earlier, that this drives so much of who they are. But at the same time, we want them to be empowered in being able to make decisions for themselves as they grow into adulthood. So I've learned a lot, and I always learn a lot from you guys. And this has been an incredible hour together. It's been great to see some familiar faces and, revisit a subject that I think we're all particularly passionate about. But, the key points here that I think we've really been able to take away is that surgical approaches and, nuances when it comes to patients who have contractions or are have complex, anatomy. Really the key here is to consider, a multifaceted approach with positioning. I think we've learned a lot about supine options when we can incorporate supine PCNL into sort of a higher stone burden in this patient population. And I think risk reduction and risk prevention, not just from a metabolic perspective, but even from a surgical risk reduction, is something that we have to continue to talk about. And, these novel technologies, especially for us as pediatric urologists, we're always a little bit behind on the wayside, but at the same time, we want to be there too. And so it's really great to hear about how helpful and how much it's revolutionized your practice in particular, Nick, when it comes to suction sheaths. And hopefully we'll be able to see more of that incorporated into our practices as well. And, like we said, I think the key here and why one of our biggest passions for Niccolo and myself in being able to have these podcasts with you and with this community is to shed light on the significance and the impacts that these patients have in the urology world and the need that we have in ensuring that these patients land somewhere safely and don't get lost into the ether. So thank you guys both so much.
Once again, I stress the importance of everybody's gone through urology training, heard this. Children are not smaller adults, so there's fewer things that you gotta consider. Chronicity of the disease, it's important. Every time I see a kid with a stone, I always tell their family this is gonna be a chronic issue. It's gonna be with you. You gotta work hard to prevent it. We'll figure out how to prevent it, but there's a very high likelihood you'll get surgery again. And, collaborating with your adult friends, always fun a colleague when you're trying to do something new with I want to do prone PCNL. Never be afraid to ask for help. Always love the boat. Go back to your intern year basics 101. It's a team sport. It's not an individual sport. And thank you guys for taking out time from your busy lives to be here with us tonight.
Great. Thank you so much.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening and see you next week.